Good afternoon, and I'd like to thank the organizing team for the privilege of this talk. Sudipta gave me this talk, ESWL in chronic pancreatitis, is it relevant? I thought it was a debate, but he said it's not a debate. I think in lunch, Rajesh told me that you take it as a debate. So we are going to look at all the options and see which is the best, and then see where does ESWL stand today. First question is, why did this question arise? This is because of this article. It's a multi-center study. We are a very much active part. There was some confusion after this study that probably ESWL does not have much role. Roop was one of the main authors. We all contributed a little. But the conclusion was very clear. There's a certain sect of people where ESWL in ERP definitely provides relief. Short term here because the follow-up was short term. We'll come to the long term in the course of my studies. So this is the reason why this topic came up. Is there a relevance for ESWL today? Now let's see, why do you need ESWL? All of us know CP is incurable. Pain is the most dominant feature, 75 to 80 presenting, and 90% will eventually have it. And whatever we do, pharmaco, endo, surgery, eventually alleviates the pain. That's the aim that we have, with a few other complications. Many mechanisms, many of them dependent, interdependent, sometimes multiple mechanisms. We are going to concentrate on ductal hypertension because that's where stones come in role. Roop has written a very nice article on the various mechanisms of pain in chronic pancreatitis. Well, clinically, there are just three situations. One, you have a ductal obstruction due to stricture or stones. Second, you clear the dilated duct of the stricture and the stones, and yet the pain persists. Other mechanisms come. Third, you have non-dilated ducts, atrophic pancreas, and pain is there. So you will have any of these three clinical scenarios in chronic pancreatitis causing pain. Now, pain can occur along with this whenever an additional organ, Mohan just talked about the biliary system. If the duodenum is also involved, you can get an outlet obstruction and pain. The causes of ductal hypertension, it's the commonest cause of pain and is either stricture or stone or a combination of stone. And in our own study of 5,000 patients, we had a 22% patients who had both stone and strictures. And this is how stones occur in our country. Head, body, and tail. Alcohol is on the rise, but most of the patients are non-alcoholic. They are young, and that's why we classify them in the idiopathic group. Overall, 50% of CPs get it. Sometimes it is beyond the duct here. There's extensive ductal and parenchymal calcification. Most of our patients come late, and that's why this photograph is available to us. Now, why we are talking of large stones? The smaller stones are removed at ERCP, a sphincterotomy and a sweep. Why are large stones difficult? What are large stones? Any stone more than 5 mm is tough to remove in the pancreas because the matrix is dense. The stones are spiculated. The diameter of the PD as well as its tortuosity makes it very difficult to pass the accessories. This is very unlike the biliary system where you have a straight duct, often dilated. So what are the solutions to get rid of these stones? I tell you, small we'll leave. Large stones, we have mechanical lithotripsy, technically there, like in the CBD. We have lithotripsy, either extracorporeal or an intraductal. Now, why is Dormia basket and mechanical lithotripsy out in the management of chronic pancreatitis with stones? One, the results are very poor. Two, the side effects are unacceptably high. And for this reason, it is not at all, not in any guidelines that an attempt should also be made with a mechanical. If you use a basket, use the mini or the spiral basket. So what choices are we left with? You do a lithotripsy. Now, lithotripsy could be extracorporeal or it could be intraductal. Intraductal you use, we are not going to the devices, either electrohydraulic and laser lithotripsy. These two are relatively, I tell you, a technique in evolution. Maybe 5 years later, I may be singing a different tune if I'm around to give a talk then. So studies in the last 10 years They are small studies. They have shown fragmentation success in the numbers that you see here. Single session 60%, but very important, high adverse effects, pancreatitis being very high. This is the same with other studies, and very late, last month, there was an article where ESWL was compared with pancreatoscopy, both EHL and laser. I don't want you to see the numbers are identical, they are not significant, even the adverse effects, but see the total number. You have total 400 cases where pancreatoscopy was done and close to 9,400 cases where ESWL was done. So the experience with laser is limited to small centers and in small numbers, very unlike ESWL, which is much more widely used. And it is for these reasons, including some accepted by the authors, that there has been a failure to cannulate and certain other technical difficulties. For example, the commonest difficulty is if you have a stone very close to the papilla and the head, it's unlikely you can pass a pancreatoscope. You need a minimum, I think. Amol, you're a champion. How much depth would you need to push in? At least 1.5 centimeters? Yes, so if you have a stone close to the opening, I don't think we can technically pass. It requires high expertise. Mind you, Amol is an expert and he's telling this. Technical skill, and still has a very high risk of pancreatitis. It is for all these reasons we go back to ESWL. And where does ESWL stand? I'll tell you where we stand today, what are the results, short and long term, and the side effects. Well, proper selection is very important. Single or multiple stones in the head or the genu with no dominant stricture, ideal for blasting using ESWL. What do you aim for? We aim to fragment it to 3 millimeters or less so that the pulverized calculi can easily slip out or be extracted at a subsequent ERCP. And this is what we have shown in our various studies. Large single stone removed after ESWL, the size of the duct also disappears. Large stone, this is in the minor, again cleared, and we pushed in a stent because there was a stricture. Even if they are large radiolucent stones are relatively easy to get out endoscopically, but sometimes they are difficult. We pass a nasopancreatic tube, inject a dye, and then we get this, we blast it off, and this is here you can see in the fourth diagram, you saw the arrow pointing out to the radiolucent calculi, and it has disappeared at the end of the procedures. All in all, over a large series, which I'm going to quote subsequently, there's been an there's an increase in quality of life for various reasons. Pain score goes down, analgesic use goes down, hospitalization drops, there's an increase in weight. And we published this about 7-8 years ago. We now have 9,000 cases where we have done ESWL with very good success. Now, these are showing short-term relief. In my earlier slide, in the index slide of stones, I told you it's a disease of the young. There's no point in having relief for 6 months. That's good for immediate relief, but what the patient wants is long-term relief. And for this reason, before that, comparative study of the various studies, the results are somewhat similar, but much more important, like I was telling, long-term pain relief. This we published about a decade ago when we had followed patients for over 8 years. 60% of patients were free, relieved minimal analgesia, and avoided surgery. This is from the same study. This follow-up is now extended close to 20 years. We published a small abstract on a 17-year follow-up of 126 patients who are doing very well. The rest, many of them are lost to follow-up in our country, unfortunately. Similar results have come both from Europe. These are 2 studies, one from Europe and one from US, which shows a smaller number of patients, 120 or so, followed up, getting similar results, 50 to 60% long-term pain relief over 4 to 5 years. So you've got a procedure where you get good results, you get good short-term relief, and a good long-term relief in the patient in the numbers that we have followed. What about side effects? I just showed you that pancreatoscopy, pancreatitis, the side effect. This is a relatively safer procedure. Our own 5,100 patients, pancreatitis was seen severe only in 0.5%. 2 studies from other centers, again, less than 6%, most of the side effects mild, only 1 mortality. So all in all, a very safe procedure. Is it the end-all, be-all of pancreatic calculi and CP? No, there are many limitations. I'm not going to discuss them in detail, just list them out. Some limitations which I'll show next are mostly theoretical, they don't happen. First is there are certain stones we are unable to fragment. There are techniques to overcome that. Then there is a recurrence of calculi, our own study shows 20%. Roop has shown that early intervention may delay diabetes, but we are still far away from establishing any benefit long-term on exo or endocrine function, and of course, not yet shown that malignancy can be prevented if you do ESWL. Certain other authors from other areas have raised certain other objections. Do we use an ultrasound for the non-radiolucent? No. The technique, why do you need to get a radiologist? You can pass a tube, outline the stone and blast it away. Some rare side effects have been reported. We haven't seen any one of these which I have listed out. Targeting may not be good, but with the newer machine and a good dedicated person running the machine, it's unlikely you will not target well, and if you target well, collateral damage is reduced. Sometimes 6% you have Steenstrasse. The fragmented stones block the duct and produce pain, and an emergency ERCP is needed. So certain rare, we haven't seen many of those effects noticed by other authors who work in the same field. So you have an excellent chance to develop, to break stones with minimal side effects and good long-term effects. So what do the international guidelines suggest? The European guidelines had the best, they gave us the best guidelines. They gave it twice in 12 and in 19, and they recommend this as the first line of therapy, ESWL, followed by endoscopic removal at ERCP. In the same guidelines, they said that per oral pancreatoscopy is a science in evolution. It should only be carried out if an adequately performed ESWL is not successful. That is so. Right now, it is relegated to a failure of ESWL. This is what the guidelines. Similar guidelines have come from ASG and the Japanese Society. All of them favor ESWL ERCP combination for large pancreatic calculi. So the 3 main syndromes: ductal obstruction, pain post-ductal clearance, a small duct disease. Concentrate on the ductal obstruction. Ramesh is going to talk to us on surgery sometime later. Endotherapy with ESWL as the guideline. So in an article that we wrote quite recently, couple of years back, we have stated, and I think this statement holds good, extracorporeal approach to management of pancreatic duct stones is a relevant option in today's management of chronic pancreatitis. Thank you.